Here we go. It's week 7. We're like over the hump now. Exam 2 is done. We have exam 3 and a HESI to go. Let you know that there is a good HESI review. I've got several different ways to give you a review that will help you. I've got what I call an open form question and answer thing. It's on my YouTube page, but I go over all the concepts you might see on an exam and go through that. And so usually the HESI grades, most of mine, my mean average is above 900. So that means hardly any remediation time if you do what I tell you to do. I also have 200 question HESI cahoots that also hit it again and again and again and again. And I know it's that repetition is what helps you learn. You don't hear it once and remember. I don't. I have to hear it a few times. So that's why I do usually that sort of a lecture, and then I hit you immediately. Let me ask you about it, and let's repeat it during the questions. It's that second time review. I mean, hopefully you could have gone through and looked at the chapters before class. I know today you've been studying for an exam. I know that's an impossibility. I'm not one to think that everybody has looked at, what's going on this week. So anyway, week 7, we did Sims and we did some NCLEX questions last week. Actually, I've actually gone through and scored most of them. If you see a 0, go back and look. Either you didn't hand it in or I need something more in order to give you full credit for it. All right. If I put a 0, it doesn't mean that you're ending with a 0. It means that, please, I just need the proper stuff submitted because I know that there's a lot of reviews and audits, and they look at stuff like that if I'm accepting things correctly. So I make sure that you have that. So this week, we do have a discussion question. Yes, this week, even with our exam. And then we do have a CJ Sims that's due also. Remember, next week is your due for your project. Only one person's turned it in. All right, any portion of it. It is quite a bit of work to do. Remember, it's 3 parts. It's a paper, it is that assessment sheet, and it's quite a few pages long, and really focus in on the last parts of it, where I'm talking about home environment and safety, and it goes into diagnoses and the theorists part of it's in there, and it's to make you think. So pick an age of a child that you understand more the theorist about. And then it is a teaching. I don't care if you teach me how to do a G-tube feeding. I don't care if you teach me how to do an MDI or an ADHD child, how to keep them organized, and what would you do at home to do that we can share with other parents of children with ADHD, okay? Because I have learned that when I first started this pediatric assessment and made it into the way that it is, I was telling my students, there's these diagnoses that the nurses where we were going to didn't know. How about you do that diagnosis and now let's go teach them. So it became a little handout with the teaching, and students were teaching RNs and LPNs, and it really worked out well. They actually enjoyed it. They were scared, but they did really well. So there is a PowerPoint and there's a Cahoots. What do you want to do? I'm not going to tell you.
Cahoots.
Cahoots.
Kahoot. All right, we'll go to the Kahoot. I knew that you're going to talk me into it, so I did pull it up. Give me 1 second. Let me get it there and ready for us.
Give me 1 second to get to my computer, and I'll be right on it.
Look at her. She want to win. Watch out for Mackenzie. She's there for you. Now remember, I can't go over the exam until all the exams are done. I will be posting the grades like I normally do, right around 2:30 on a Saturday. You can ask me, to meet. You can meet before class, after class. Those are some great times for you students who, are busy and you're coming from one and leaving one. I can do it then, or another time. You just let me know and I'll work with you. All right, I'm just gonna go. I'm gonna get started. Whoever needs to come in can come in when we get going. So here we go, week 7. It's a lot of interesting things, endocrine and cerebral. So it's a lot of important information. I'm going to try to get it into this. Growth hormone is administered by what route? Your pituitary gland secretes growth hormone. When you don't get enough, you're going to be a very short child. This is why we do height and weight on every visit, whether you're ER, urgent care, doctor's office. When you are very short and your parents want to take on the undertaking, it is a subcutaneous injection. Daily, twice a week, weekly, they're all different. But it is subcutaneous. It's like giving yourself insulin every day. So those parents and children who want to do that to get them a little taller are saying, I'm going to be taking sub-Q injections, whatever the routine is. Let's say it's daily until I stop growing less than an inch a year. Once you're still growing an inch a year, they'll continue it and then they'll stop it. But it is a sub-Q injection. Lupron. A highest priority for a patient diagnosed with a syndrome of an inappropriate antidiuretic hormone. Look what that says. Antidiuretic, against urinating hormone. Inappropriate, too much of no urinating hormone is being delivered. What's going to happen? Again, this is pituitary gland. This has to do with diabetes insipidus. The opposite is the syndrome of inappropriate antidiuretic hormone. Again, pituitary gland, posterior. This is something that is all about fluid. When you're talking about fluid balances, always remember intake, output, and then daily weights, especially on this one where you are gaining weight. You're not urinating, anti-urinating hormone, okay? So intake and output is going to show that you're not urinating enough. Which of the following are signs of syndrome of an inappropriate antidiuretic hormone? What did I just say? Again, don't look at that word and go, oh my goodness, I have no clue. Break it apart. Look at it. It makes sense when you pull it apart. Antidiuretic, against urinating. I'm not urinating. What are you going to see? Decreased urinary output. Could be increased weight too, right? Very good. What is important to cover when teaching a family about polymyxopacil? This is something we give for hyperthyroidism. There are specific warnings on it that we give. Medications does what they need to do. They block the thyroid hormone from being produced, but this one causes leukopenia. It's for hyperthyroidism, okay? Too much thyroid hormone. But there's also, it does render you leukopenic, which means you don't have enough white cells. Not enough white cells, you can't fight infection. What do you see? Risk for fever or a sore throat. And that's what the warnings are. A multi. An initial sign of diabetes insipidus. This is the opposite of syndrome of inappropriate antidiuretic hormone. This is a diuretic hormone. It's telling your body, go ahead, urinate, 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 urinate. But the body's also saying, well, I'm losing all this fluid. I'm thirsty too. So this is two P's. Now, polyphagia is diabetes mellitus with the other two P's, okay? But diabetes insipidus, posterior pituitary gland, is all about urinating and thirsty, polyuria, polydipsia. Polyphagia, as I said, diabetes, you're hungry, you can't eat sugar, you're hungry. A multi. What are the clinical manifestations of juvenile hypothyroidism? Well, if you're an adult, you have symptoms. You're going to be that person with that cold intolerance. You're going to see that dry skin, constipated. But the one, maybe weight gain. But the one thing about juvenile hypothyroidism is you need it for your growth. Okay? Without proper thyroid hormone, it's growth. Adults, they don't need that anymore, but it is everything else, that dry skin, sparse hair, constipation, cold intolerance. Weight loss would be more hyperthyroidism. Hypo means not enough. Usually it's weight gain. A child has a simple febrile seizure. What education would you provide to the parents? My firstborn grandson had a febrile seizure at 18 months old. Only one ever. She carried a thermometer and medication around constantly, so they never had a chance to get another one. But what do you need to teach these parents? Well, the one thing is all about safety. What do I do if my kid has a seizure, right? Make sure that they're, if there's, you see them falling, well, if you could catch them. If not, turn them on their side. Make sure stuff's around them that they can't hurt themselves with. Many times they will vomit. Sometimes they won't, depending on how long it goes for. And remember, one seizure does not make a child epileptic, okay? You need 2 or more unprovoked with no fever seizures that would declare that the child would be epileptic, okay? So safety precautions, teach them what to do. They can't put anything in the mouth, all of those things that we know. What type of seizure is when the body's jerking, foaming at the mouth, and the child is rendered unconscious? Well, that's not your febrile seizure. This is the big one. And it's that rendered unconscious, that postictal. That's what's telling you here. Years ago, we used to have petite mal and grand mal. Today, there's no more grand mal. It's called tonic clonic. Okay, good. Good job. What notable sign may indicate increased intracranial pressure in an infant? You could go into a room with a lot of babies, and one has a neurological something's going on. You will know that child is a neuro child because of one thing. It's the cry. It is, put your nails on a chalkboard, it's higher. It's not a normal baby cry. And you're going to say, ooh, that kid is neuro. What's going on there? Bulging fontanelle when crying? No. If they had increased intracranial pressure, it would always be bulging because it should be swollen, right? And those are the two things that you chose. But high-pitched crying is the answer there. All of the following increase intracranial pressure except what? Taking care of a child, adult with increased intracranial pressure, you need to know what safeguards, right? You need to know what can spark issues and try to avoid them as at all possible. Heart rate has nothing to do with pressure, okay? Tachycardia, bradycardia, it doesn't matter. But too much fluid does increase it because you're increasing the pressure in the head by extra fluid. coughing, suctioning, you're creating that pressure there. What findings can alert you to a head injury getting worse? Many children's come into the ER, slid into third base, hit, the defender, got knocked out, right? Sliding in, and they come into the ER. And the one thing you're going to always hear, was I safe? Did I make it safe? Did I get there? It's all about the change in mentation, decreasing level of consciousness. Absolutely is the biggest one, that change in orientation. You might see, if it got even worse, headaches that will actually wake you up from a sleep, and vomiting, which has nothing to do with when you ate. When you start seeing those things getting worse, again, that's another thing. But the first thing is that level of consciousness. A multi. What does it mean when you see a fixed and dilated pupil after a head injury? I've seen kids fall off of second-story balconies onto the ground, be brought in by rescue. And the first thing we always do is look at pupils. Why do we look at pupils? What's that so important about? Well, it's telling you if they are not reactive to light, the pressure in that brain is so much. If we don't get that pressure relieved quick, it's probably going to be a permanent, and it's a brain stem damage. Now, what is the brain stem? This is your breathing, this is your respiration, your temperatures, your basic body function. That's all you're going to have left, and the rest of it is gone. So these children will not be alert at all. They'll just be there, that we're just taking care of. So it's an absolute neurological emergency. They need that neurosurgeon coming in and getting that pressure relieved immediately, especially if there's one of them that's telling you this side of the brain. If it's this side, this brain is swelling up, and a lot of damage is going to occur if we don't decrease that. So what medication can be used for a child with cerebral edema due to a fall? Now, we learned about diuretics in pharmacology. We learned about decreasing fluids in the lungs peripherally, and one of them was for the brain or renal failure, or maybe a toxic, when you took in something toxic, and it is mannitol. Remember, mannitol is that specific for the brain, and it comes in a glass bottle. Make sure there's no crystals in it, and we give it, and it's like an instant, like diuresis, and it takes the pressure off quickly. Furosemide, congestive failure, peripheral edema, yes. Heads, mannitol. Remember that, mannitol. Rey syndrome. What's that? One of the things that we tell our parents is never to give aspirin to your child unless they're Kawasaki disease, right? Or if the physician ordered it, because it is a rare, but it's a metabolic disorder caused by aspirin, and it's in children, okay? So it's all of those things. And one of the things, as we're teaching fever control, is something we should mention, because if that's all in the house, the parent might give it to them. The fever's not going to hurt a child. You know that. Once they have a fever, they're safe. It's when it goes from 0 to a fever in 20 seconds or 20 minutes, that rate of rise causes that febrile syndrome. So it's better nothing than it is to give aspirin on a child. Febrile seizures usually occur in what? Like, how old do you have to be? And the great thing about febrile seizures is they usually grow out of them. And that's one thing parents look forward to. Usually 6 months to 6 years. But my daughter-in-law with my grandson who's 11 still carries a thermometer and still takes his temperature regularly. Childhood hypopituitarism results in what? Remember I told you one side is all the fluids and the other side's about growth. That's the growth hormone, the anterior posterior gland, right? Posterior is all fluid balance, all about holding it or getting rid of it. So if you don't have enough growth hormone, hypopituitarism, you're going to be a dwarf, you're going to be short. And that's just part of it. How would you describe precocious puberty? It's an endocrine disorder that we see it in boys and girls. And it's all about getting to puberty too quick. And the reason why this could be an issue is if you're a 6-year-old and you have breasts and a bra on, can you imagine what the other kids would say? Boys could get a beard. I mean, it is an issue with boys and girls. So we can give stuff to stop it. And that's when we would, because we don't want that to happen to our children at that age. They're too young for that. I can't imagine my grandson with a beard. No. A multi. What lab values are important to monitor with a child with congenital hypothyroidism? So, what are thyroid hormones, right? That's all you need to know. Now you're going to get them all bumbled and mixed up: thyroid, adrenal, pituitary. Remember to try to keep them separated because there's going to be questions regarding one or the other. I try to break it down in this cahoots. T3, T4, TSH, that's all your thyroid. That's what you need to be concerned about. Growth hormones is pituitary and cortisol is adrenal, just to let you know. How can you monitor a child with hypo or hyperthyroidism? How did I tell you we monitor them? Well, we're going to be doing their levels, but what would make us do a level on a young child? What's the one thing different with children? It's all about growth, right? Growth. So one of the reasons why we do height and weight every visit is number one, making sure that they're healthy, gaining weight, because we need nutrition for the brain, cognitive, and also, do they have enough hormones like thyroid that they're getting tall enough? Do the growth hormones would be one of these things too? Height and weight on children are so important, and that's why we do it, because we look at it for many, many reasons. That's just another. What acid-base alteration would you see in a diabetic with Kussmaul's respiration? What is Kussmaul's respiration? Now I want to try to describe what DKA is to you. How's that? That is respiratory alkalosis. Well, the body is really neat. When you have diabetic ketoacidosis, you have your body not using sugar. So we're burning up fat and proteins because sugars are just going away. That's why your blood sugars are up to 1,000, right? And then your body eats these other protein and fat, and then ketones are a byproduct. And it causes metabolic acidosis. Kussmaul's is so specific to DKA because it's trying to do the opposite of what your body did in DKA. So if you're metabolic acidotic, respiratory, we become alkalotic to try to compensate. It's our body's own compensation for what happened because of the metabolic acidosis in DKA. A multi. What would a child with Cushing's syndrome look like? This is the adrenal gland. Cushing's. Cushing syndrome is usually due to too much cortisol or too much prednisone, cortisone being taken. When I first became rheumatoid arthritis, they finally said, yeah, okay, yeah, you do have it. They finally believed me. They put me on a high dose steroids and I gained like 60 pounds. My face was a big moon. I had hair on my chinny chin, and I had, the trunk got a little pudgier than normal. It was all Cushing syndrome. The great thing about it, usually the arms and the legs are still skinny. It's the trunk, the face, and the red ruddy cheeks. And ruddy is another actually word for red type of looking. Cushing syndrome, the way that we correct it, if it's due to taking steroids, we taper the dose off. You cannot just take off steroids, especially if you've been on them for a while. That's why we taper doses. Ever see a Medrol dose pack? We go from 7 pills to 1. We're tapering it, and that's the way that we do it. A multi. You walk into a child's room with a fever of 104.6 and you see them having a seizure. What can you do? Again, this is like what you're going to teach a parent. What are you going to do if the child is having a seizure? Febrile or otherwise, what are you going to do? So you definitely making sure they can't harm themselves, put them on their side. If you can, pad the side rails, but at least put them up so they don't fall off. And, when you're doing that, of course, you're calling for help. In case it continues on more than just a febrile seizure, it could go into status. We don't know all of our children if they all have a history of seizures, might be a first one, but it can go on and on and on. So very important safety in seizures. Autoimmune disease of the thyroid gland. Now, an autoimmune disease, we only treat this with medications. It could be T3, T4, levothyroxine, and another thyroid hormone. And that needs to be monitored closely for life. That thyroid gland, you cannot remove it. That one, you just have to treat it with medication. And the name of it's called Hashimoto. Hashimoto is an autoimmune thyroid problem. It's usually females, usually rated at adolescents, that they are diagnosed. Addison's disease, Cushing's, Addison. Cushing's, Addison. Okay, so what would that mean? A lot of times Addison disease ends up with a child with ambiguous genitalia because they don't have enough adrenal gland. And it is a decrease in cortisol and aldosterone. These children who have this ambiguous genitalia, they're going to have an assignment made what sex they are. They could have a penis and a vagina, testicles and a vagina. They're all different types of combinations. I've only seen one in my whole lifetime, but it was like, what is this? It's confusing. Remember, it's hard on the parents too. That okay, so what did you have, a boy or a girl? I guess it's a girl. It's hard. It's just a very hard thing. But cortisol and aldosterone is the treatment. It is for life. And again, with any sort of stress, they might need more cortisol, more aldosterone, to keep up with it.
I have a
That's
question.
adrenals. Oh, let me finish this and I'll answer it. Not a problem. A ventricular peritoneal shunt. Well, it's the ventricle in the brain. And it's a tube that runs down the back of the head, down the front of them, into their peritoneum. And why do we do that? We use it for extra fluid on the brain. What is our job as nurses? Well, we're going to be measuring head circumferences every day, every shift when you come on. There is a pump there. You are never to touch it. Leave it alone. That's for the neurosurgeon. And again, weights, because we can see fluid gain from that too. What was the question that you needed?
Yes, so it might be a silly question, but going back to, if a parent has to pick between if their child will be a boy or girl, can they not look at a cellular level and see what chromosomes they have?
They do. They'll go and do hormones and they'll do ultrasounds, x-rays. They're going to try to figure out what's inside to try to make the best choice. But we know today, look at those Discovery Channel things, boys being girls and girls being boys. They're confused. It's just the parents have to make a decision. Is it a boy? Is it a girl? And that can lead into like problems later on in life. But yeah, they do. They try to pull out blood, try to figure out what is the best for the child. It's a good
It can
question.
be hard if they have a penis and a vagina, though.
Yes, it is. Yes, it
Is that a hermaphrodite? Is that what you're talking about? Will they have
basically.
both?
Yeah, it's called, ambiguous genitalia.
I have
It's
Well,
seen
I was just thinking, if they have an XX or if they have an XY chromosome, that should be enough to tell you what they actually are. But I guess it's not that simple.
It's not that simple.
Well, I've
It's not
seen a
that simple.
twin. One was male, one was female, but he had breast and the penis, but she had breast and a penis, and they both had the vagina, where she had the vagina where he had breast and a penis, but she had vagina and a penis along with the
Yes,
breast.
it gets so
But
complicated. It is
female features with the male, and he had male, but he still had some female features too. It was really messed up.
and sometimes it's just a very prominent clitoris. Sometimes it looks like a penis, but it's not really. So again, it's that investigation looking for it. What is the best for the child? And who knows if it was the right choice? Because they'll do corrective surgery starting out, when they're very young. Because we know we want everything that has to do with their body parts and potty training done before they start potty training. That is the goal. A common sign of Graves' disease includes blank or protrusion of the eyes. Graves' disease is hyperthyroidism. So it's exophthalmos. You guys knew that one. Good. Another multi. Hypoparathyroidism has the symptoms of tetanic muscle contractions and blank. Well, what does the parathyroid regulate? That's how you know this answer. Tetanic muscles. Muscles and electrolytes are always magnesium and calcium. Whether it's adults, whether it's children, when you see it's flaccid or tetanic, all has to do with either calcium or magnesium. Questions like that, med-surg, you're going to see it. Now, parathyroid regulates calcium levels. When you have tetanic muscles, you have low levels, okay? That tetany and muscle weakness, that's part of it. Has nothing to do with your vitamin D level. Another multi. What are the signs of hyperparathyroidism? This means too much calcium, right? It gets to the point where you can't move, literally. So you have a thyroid, and that's all thyroid hormones. And a parathyroid has nothing to do with the regular thyroid, okay? So they're two separate entities, but they're both right there close to each other. So you're nauseous, vomiting, confused, and you are so calciumed, you don't even feel your extremities anymore. And it's hypercalcemia. What does the parathyroid hormone do? You should know that now. It regulates the calcium in the blood. Parathyroid is only about calcium. Which of the following may be a cause of an adrenal crisis or an Addisonian crisis? Has to do with Cushing's disease, has to do to inappropriately treating it. It's one of the clues there. And it's that abrupt withdrawal from steroids. You wouldn't go from 20 milligrams a day and then just stop. You need to break it down, slow it down, and then your body gets used to it, or it will go into a crisis. And they're scary. A multi-select. A cardinal sign of diabetes insipidus. I told you earlier. Now, which ones are they? Diabetes insipidus or syndrome of inappropriate anti-diuretic hormone. Remember, it's all about fluid balances. That's it. It is polyphagia. It's only diabetes. When you talk about fluid balance, DI, diabetes insipidus, or SIADH, that's fluid. Polyuria, polydipsia. Polyphagia is only when you add diabetes mellitus in there. And diabetes insipidus, you're urinating, I'm thirsty, 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 thirsty. They say infants with diabetes insipidus will be screaming and yelling for a bottle, and you give them milk and milk and milk. And all of a sudden, you give that infant a bottle of water, and they're satisfied. And then you're like, oh, this is diabetes insipidus. A multi-select. Congenital hypoplasia parent teaching should include again, that is your ambiguous genitalia. They will never have children. They don't have the parts. They will be cortisone, aldosterone for life, and then get extra ones as they need due to stress or illnesses. And they do need their gender assignment. Are they a male or female? And absolutely need genetic testing done.
I have a question.
Sure.
Is that different from adrenal hyperplasia?
It's the same thing.
Okay.
It's called both. It's called both things. Congenital
Okay.
hypoplasia, or it's the ambiguous genitalia too.
Okay. The reason why I'm asking is because I have a nephew with adrenal hyperplasia.
Okay.
He just had a baby, and he was very much a boy at birth.
That's very unusual. Wow. Oh, I'm going to look that up myself.
And I actually took care of a patient one time who had adrenal hyperplasia, and he was a father.
Hyperplasia.
Okay, that's the difference.
I think that's it right there.
Okay, because I was going to say I had another patient that had the same disease, and he was a father also.
Okay.
So, okay, that's the difference.
I'll look at that though. I'm very interested in knowing the difference myself between both of them. As I said, I've seen one in my whole lifetime, and you may or may not ever.
Yeah, I've only met two with the adrenal hyperplasia.
Okay. All right. Thank you. Appreciate that. What causes type 1 diabetes? we know type 1 diabetes is because the pancreas, it's destruction of the beta cells, it's autoimmune, it is, immunosuppressive disease, and it destroys them. So it doesn't make the insulin, and it can't eat sugar, and it can't process it, and the body can't use it. And that is type 1 diabetes. Which statement about a pheochromocytoma is correct? This is an adrenal tumor. It's an interesting tumor. This is one of those tumors. It's very hard to diagnose. It's very hard to find. This is a tumor where if you manipulate the abdomen and palpate it, it sort of breaks off, and epinephrine goes out into the body. So it's catecholamine, means sympathetic. Everything is up, heart rate up, blood pressure up. Patients get chest tightness, headaches from it, and they think it's the heart. They think this elevated heart rate, blood pressure is due to the heart. And then they rule that out, and then they look at the adrenals, and then they can remove that tumor. But it's a catecholamine producing tumor, and it's not all the time, it's intermittent. These are very challenging. These patients need to be monitored closely when they start saying, I feel like my chest is bouncing, my heart rate's going. You do vital signs a lot on those. A multi. Which action should the nurse implement in the care of a patient with a pheochromocytoma? They finally figured out what it was. And usually they bring them in, watch them, and get them scheduled for our OR to get it out. And again, we are going to be monitoring for heart rate and blood pressure. Has nothing to do, this is adrenal gland, nothing to do with sugar. Sudden weight gain has nothing to do with fluid balance. That's the pituitary gland. A multi-select. Nursing care of the unconscious child include what? No, we would like to think that you're not going to see any sick children, that they're all going to be good, and no one's going to go unconscious. But, you do get sick children that are in the ICUs, newborn ICUs, PD ICUs for long periods of time. And what we do with the unconscious child or adult, we're going to be doing neuro checks, seeing what their pupils are looking like, especially Q2 hour in the very beginning of this time. Vital signs will be watched, and we're going to be monitoring strict I&O. Too much fluid goes in the brain, causes pressure, can cause more problems. So we don't want to fluid overload these children. That's why we watch it. Pain control is not the priority. It's more on watching their neurostatus and their fluid balance. What might you suspect if a child feels jittery, sweaty, and is dizzy? What do you think that could be? So this is a hypoglycemia response, right? Probably low blood sugars. We don't know what all children have. One might just see one there and they're getting jittery and sweaty. Well, I would ask, are you diabetic? Okay, let's give you some sort of sugar. Let's give something to eat. And then remember, it's not just giving a little bit of sugar or a sugar dose or a sugar packet. It's getting some protein in when they're done too. They need both of them to keep that from happening. Symptoms of DKA are so you eat sugar, the body doesn't know how to use it, so it goes off into the system and you have elevated blood sugars. Then your body says, I'm just still really hungry. So it starts eating fat and proteins, byproducts being ketones. Now, fruity breath, because the blood sugars are so elevated that the sugar just oozes off of them. And ketonuria, those be like 4+ positive, because that's the body breaking down other types of food so it can feed it, okay? So this is what you see with them. Literally, these children or adults, if you put them in a room, close the door when they come in this, like in the ER, you smell a breath that is so unmistakable. Take a peach, put it in a refrigerator in a Tupperware jar for 2 months, a month, a long time. Take it out, open it up, and you have a rotten, sweet smell. That is what it smells like. It's very distinctive. A multi. An adolescent with a BMI above 95% has been urinating a lot. What tests can you anticipate? Like, what could that be? Well, you have a hint. BMI is 95%. That's an obese adolescent, right? Quite heavy. And they're urinating a lot. What could that be? And what do you worry about? So we're going to be doing a urine just to look at it. We're going to be doing that hemoglobin A1C. Is this a diabetic child? Especially being overweight and urinating. Those are some symptoms of it. And then because they're urinating, you want to make sure that they didn't lose their potassium, right? Always you'd be checking that. Pregnant don't have those symptoms. They do not. Diabetic ketoacidosis is caused by, I've said it like 3 times now. You should get this answer. So it's a lack of insulin. Body can't use the carbohydrates. So it goes to protein and it goes to fats for fuel and energy and nutrition. And that's the answer there. Okay. A multi. A child's admitted with a blood sugar greater than 600 with large ketones in the urine. What is your priority here? What do you need to do first? These children come in, they're pale, they're lethargic. Even like the adolescents come in, they're usually wheeled in a wheelchair. They're so weak. They just look, lethargic. You want to get an IV in there quick and you want to dilute that glucose. And you're going to put up a slow, continuous, regular insulin drip and monitor that blood sugars coming down. There are set priorities, taking care of DKA with large blood sugars. And that's the way you treat it. Dilute it and then the insulin in order to get it down. After that priority, then we start worrying about the electrolytes and everything else, because you will be losing potassium there also. But priority is the IV bolus with insulin. A diabetic child complains of feeling jittery. The blood sugar is 45. What's the best treatment for this child? And if you read the question, the child is complaining of feeling jittery. Again, that's reading a question. It's like, 45, that's really low. I had a friend whose doctor's office called them on Monday and she had blood taking on Friday and her blood sugar was 36 and she felt fine. So 45 is all right. It is low. They're jittery. They are having symptoms. Glass of orange juice. How about a glass of milk? That's fine. But again, remember, they need something like a turkey sandwich, some protein after that in order to maintain it and get their blood sugars up. You can't just eat sugar because the sugar's not used again. So you got to give something else that protein. Your patient has experienced a head injury. What would most concern you? So number one is the level of consciousness. We've already gone over that. So what else here? This is a really difficult concept on this one right here. Head injury, head swelling. Now it's pushing on the pituitary gland. You're not having any urinary output. That would be a key sign that the fluid is building up. And what would you give for head injury? Decrease in urine output, fluid in the brain, mannitol. Okay, we put it all together now. A multi. How do you detect diabetic ketoacidosis? And what are the three signs of diabetic ketoacidosis or diabetes? It's polyphagia, polyuria, polydipsia. It's 3 Ps, right? So that being said, what do you see? Elevated blood sugars, you're eating, ketones, because it's not using that sugar, and then the 4 plus glucose in the urine. Absolutely. Those are things we, tell them, if you can, give me a urine, and we're quick dipping that right away as we're starting an IV, getting that fluid in, and then as we see those blood sugars, we're going to be starting that regular slow insulin drip. A multi. What would alert you that a child's head injury is deteriorating? Kid slid into third base, was knocked out, came into the ER. Still wants to know if he was safe into third base, or was he out? Or did we win the game? Did we win the game? Those are things. They get confused when they start to be difficult to arouse, that you really have to shake them to get them alert, something's wrong. And then restlessness, remember that's hypoxemia to the brain. That means there's swelling going on in there. And then headaches getting worse, waking them up at night, and even vomiting. You will see not related to eating. So all of those things. Did good there. A child's been diagnosed with bacterial meningitis. What's the nursing priority of care? Bacterial meningitis. Now, you'd be surprised, most meningitis are viral. Most of them. How do we treat it? Ibuprofen, acetaminophen, rest, fluids. But how do we treat bacterial meningitis? Your priority is making sure those antibiotics are given on time. Okay? That's number one priority. Okay? Because the antibiotics are going to take care of it. And with bacterial meningitis, these children must be on strict isolation for 24 hours. They need 24 hours of antibiotic before we can take them off of it because it can be transmitted. What is the primary cause of an injury associated with submersion? I live in South Florida. I've seen quite a few drownings in my life. And some of them are up and out and moving right away, right? And they're like, we're taking you to the hospital. And you're like, well, why? Well, what happens with submersion, they go under, water fills the lungs, and now they're not getting oxygen. You have up to 72 hours that they can become with that acute respiratory distress syndrome. Like I said, week 5, the hypoxemia is what can cause that there. So just a reiteration, up to 72 hours. So these children are brought in and put on a SAP monitor and monitored closely. And last question, a multi, of course. What CSF lab values correlate with bacterial meningitis diagnosis? I used to love working in the ER and have children come in with all the classic symptoms of meningitis and then do the tap and then wait for the labs to come. Well, I know by looking at that little fluid that comes out. If it's not clear, it looks milky or even milkier than what you just saw, absolutely it's bacterial. And what you see is low glucose because the bacteria loves sugar and it eats it up. So glucose is down and they don't care about proteins, so proteins are elevated. And you're going to see a whole bunch of white blood cells, sometimes too numerous to count. And that's what makes it really milky. So what am I anticipating? Okay, doc, what antibiotic you want me to start? Because you need to do that now. And we want to get these children safe. So that was today in a cahoots. Christina, good job, Christina. Number 2, Thomas D. Good job, Tom. Number 1, meh, it's just meh. And Jen in the future NICU nurse. Everybody, it was a good class. As I said, I'll have that stuff posted for you that you will be able to get your grades on Saturday. I mean, some of you are asking me if you can breathe. That's about all I can say at this point. But remember, anybody who wants to review an exam, I don't care if you have a 98 or if you have a 78 or a 58. It doesn't matter to me. I want you to get a hold of me and let's go over it because these concepts you're going to see again on the HESI, okay? Thank you, guys.
Are you meeting with anybody right now?
No, I'm not.
Can I just ask one super quick question
Yes,
before
you may.
you meet someone? So I was just looking